Balakrishnan?
Yes, sir. Am I audible, sir?
Yeah. Please stick on to the time. You are allotted 25 minutes from now.
Yeah, sure. Sir. So good afternoon, everybody. At the outset, I would like to thank IAP TNSC for giving me this opportunity to be part of this wonderful CME on neonatology. So my topic for today is the gist of basic NRP, or as rightly pointed out by Thirumurugan sir, it's the essential NRP. So my outline of my talk would be, I would be dealing on transition at birth, the need for resuscitation, how to prepare for resuscitation, and what are the various steps of resuscitation up till the bag and mask ventilation or the positive pressure ventilation and the ventilatory corrective steps. Following which, Dr. Uma Maheshwari from SRMC, she will be talking on intubation, chest compression, and medications. So one of the most complex physiological adaptation in the entire human life is the transition that happens at birth. So this is the fetal circulation. As you can see here, the oxygenated blood from the placenta goes to the heart, and from the heart to the systemic circulation. And the amount of blood that goes to the lung is less than 10% of the cardiac output. So majority of the blood goes to the systemic circulation. And what happens soon after birth? The lungs, which are fluid filled, change to an air-filled organ. As we clamp the umbilical cord, the systemic resistance increases. And as the lung expands, the pulmonary vasodilatation happens, and there is increased pulmonary blood flow, which helps in oxygenation and ventilation. And subsequently, the foramen ovale and ductus arteriosus close. So what can go wrong during this transition? The lungs may not be filled with air, which will result in inadequate ventilation and oxygenation. As you can see here, the lung fluid should go out and the air should replace. And foreign materials such as meconium may block the air from entering the alveoli. And a failure of lung expansion may cause persistent constriction of the pulmonary arterioles, resulting in pulmonary hypertension. And because of hypoxia and ischemia, it can result in hypotension. So hypoxic ischemic insult can cause multi-organ dysfunction involving all the organ systems, especially the CNS, which can result in both short-term and long-term mortality and morbidity. So the aim of resuscitation is to facilitate this transition in the neonate so that we can prevent hypoxia and ischemia in our neonate. So this is a pyramid approach in neonatal resuscitation. As pointed out by Dr. Thiru sir, all the babies require immediate assessment at birth and just simple newborn care. Only about 5 to 10% of the babies require simple stimulation to help them breathe, like drying and rubbing. About 3 to 6% may need basic resuscitation in the form of bag and mask ventilation and positive pressure ventilation. And less than 1% need advanced resuscitation. So this is to emphasize the point that most of the babies would need basic resuscitation. And at least one provider who is competent enough to provide positive pressure ventilation should be present at the time of delivery of all the newborns. So a job well started is half done. So preparation at birth is key. So anticipation helps us to be prepared better for the resuscitation. So how to be anticipated? So we need to ask 4 questions as we enter the delivery room or the theater. What is the gestational age? Is the amniotic fluid clear? How many babies are expected? Or is there any other risk factors, like we have to go through the antenatal risk factors like oligohydramnios, abnormal anomaly scans, eclampsia, preterm deliveries, or if there is any intrapartum risk factors like abnormal CTGs, or is there any antepartum hemorrhage, cord prolapse. So we have to take into all the risk factors, and this risk factors has to be asked from the obstetricians once we enter the delivery room or the theater. So one qualified person who is skilled in performing positive pressure ventilation should be present for all the deliveries. And in the presence of any risk factors, 2 persons who are qualified in performing neonatal resuscitation should be present during the neonatal resuscitation. And a qualified team with full resuscitation skills, like you're getting umbilical vascular access, chest compression, intubation, should be present in the vicinity to help you. So NRP is all about teamwork, and communication are key requisites for any neonatal resuscitation. And for the team briefing has to be done before any resuscitation, and for which we need to assess the perinatal risk factors. We need to identify a team leader who needs to delegate the tasks to various team members. And we need to identify who will document the events and determine what supplies and equipments that will be needed for the resuscitation. And we should also identify how to call for additional help. So once we've done with the team briefing, we should go ahead with the equipment check. And we should make sure throughout this process of preparation and during the process of resuscitation, aseptic precautions are correctly followed. So as we go through the equipment check, it's easier to go through based on what we do for the newborn during the resuscitation, like warmth. So for warmth, we need a preheated warmer, which should be switched on at least 15 to 20 minutes prior. We need at least 2 to 3 warm towels or blankets. For a preterm delivery, we would need a plastic wrap and a thermal mattress. And for clearing the airway, we need a bulb syringe or a mucus extractor. If it's a suction catheter, we need a 10 or a 12 French suction catheter, which is attached to a suction mounted, which is about 80 to 100 millimeters of mercury. And for auscultation, we need a stethoscope. For ventilation, we need the PPV device, which could be either a bag and mask or a T-piece resuscitator. And we also need appropriate size mask and a feeding tube. For oxygenation, we need equipment to give free flow oxygen, oxygen tubings. If possible, it's better to have a blender. We'll need a pulse oximeter to assess the oxygenation. And we also need a target oxygen saturation table as well in order to titrate the FiO2. With regard to intubation and medication, Dr. Uma Maheshwari will be dealing with these equipments. So this is the NRP algorithm that we need to follow during our resuscitation. So this is to highlight the importance of various sequential steps that we need to follow during the neonatal resuscitation. As we are all aware, in an adult, the most common cause of arrest is cardiac arrest, whereas in a neonate, it's always respiratory. And hence, we need to follow these sequences, especially positive pressure ventilation, before we do intubation and chest compression. So when we have a neonate who does not breathe or who is apneic at birth, we should go through initial steps first. Then, if the baby is not responding to the same, positive pressure ventilation, then assessment. If the baby is not responding, we have to make sure the ventilation that we are giving is effective by doing the ventilation corrective steps. And in spite of effective ventilation, if you're not able to achieve the desired response, then we have to go ahead with intubation and chest compression. Still no response, then we go ahead with medication. So at no point we should not miss out on these sequential steps. And always positive pressure ventilation comes way ahead. So as a baby is born, so what is the assessment that needs to be done? We need to ask ourselves 3 questions. Is the baby term gestation or preterm gestation? Does the baby have a good muscle tone? Is the baby breathing or crying? If the answer is yes, then we go ahead with routine care, wherein the baby stays with the mother. We provide warmth, maintain the normal temperature, position the airway, clear the secretions only if needed, dry the baby, and do ongoing evaluation. So this should be the norm for all the deliveries wherein the baby cries at birth and the baby satisfies all the criteria in the assessment. So we provide warmth by placing the baby skin to skin with the mother and covering the baby with the warm blankets. And we don't have to do routine suctioning for all the babies. We need to clear the airway only if it is obstructing or if there is any copious secretion. And we continue to do monitoring the vitals, especially the breathing, color, as well as the temperature. So one of the interventions that can go a long way in helping both the preterm and term babies at the time of birth is clamping of the cord. So as you can see in this diagram, a baby who is born with early cord clamping has a blood volume of around 70 to 80 ml per kilo. If you're able to delay the cord clamping by about 1 to 2 minutes, the blood volume goes up to nearly 100 ml per kilo. So how does it help? Especially in preterm neonates, it increases the circulating blood volume. It reduces the mortality as per Cochrane. It decreases the IVH in all grades. And these preterm babies have less needs for inotropes as well as less need for transfusion on the long term. And in term neonates, there is less iron deficiency anemia because this extra amount of blood gives a better iron storage for these babies, which can last even beyond 6 months. So As per the NRP guidelines, we have to delay cord clamping for longer than 30 seconds, but preferably it will be better to delay cord clamping by at least 1 to 2 minutes after birth. So what if the baby is not crying? So if the answer to any of these questions, like term gestation, good tone, or breathing or crying, if the baby is not crying, what should we do? We should perform initial steps, wherein we provide warmth, position the head and the neck, clear the secretions, dry the baby, and stimulate the baby. Let's see how we go about it. So how do we provide warmth? So if the baby is not breathing or crying, the cord is cut immediately and the baby is transferred to the warmer, and warmth is provided by placing the baby underneath the warmer. And positioning, baby has to be positioned in a neutral position or the sniffing position. And we should make sure that the baby is not either hyperextended or hyperflexed, which can block the airway. And once we have positioned, we need to clear the airway. Again, no routine suctioning for all the babies. We need to clear the airway if the baby is not breathing, if the baby has poor tone, if the airway is obstructed, or the baby would need a positive pressure ventilation. And suction has to be done first with the mouth, followed by the nose. As said earlier, we should use a suction catheter of 10 to 12 French with a pressure of around 80 to 100 millimeters of mercury. And after we have suction, we should dry and do tactile stimulation, but it should be limited to drying, rubbing the back and the soles of the feet. There is no flicking of the soles, which is taken off from the last NRP. So this is the most controversial thing about meconium stained amniotic fluid. So what should we do about it? So we classify the babies born through meconium stained amniotic fluid as one, vigorous infants. Vigorous infants are the ones who are crying, who are breathing, who have a heart rate of more than 100, and who have a good tone. So these babies, they stay with the mother. We do oral and nasal suctioning if needed. With regard to non-vigorous infants, they're resuscitated in warmer like other babies. We do initial steps, including oral and nasal suction, wherein the routine intubation and endotracheal suctioning, which was recommended earlier, is no longer recommended, because the emphasis now even for these babies who are born through meconium stained amniotic fluid is ventilation. So we should not waste time in going ahead and doing an endotracheal suctioning. Rather, we should go ahead with positive pressure ventilation in these babies. So once we are done with initial steps, we have to go ahead with initial assessment. We look at the baby's respiration, look whether the baby is breathing or baby is gasping. And we listen to the heart rate. Auscultation is one of the most sensitive ways of looking at the heart rate, wherein we auscultate for about 6 seconds, count the beats for 6 seconds and multiply by 10 in order to get the beats per minute. Palpation of umbilical cord can be done, but it is less sensitive compared to auscultation. So the latest NRP is to introduction of ECG electrodes in order to pick up the heart rate early, especially in preterm babies. Pulse oximeter again can be used to assess the heart rate, but it does take a few minutes time before we can assess the heart rate through a pulse oximeter. So now that the baby is breathing, so if the baby's breathing is labored or the baby is having persistent cyanosis, what should we do? So again, we go back to the basics, position the baby, clear the airway, and very important, we connect a saturation monitor and we give supplementary oxygen based on the saturation. And if the baby is having increased work of breathing, then we should consider CPAP. So oxygen administration, very important, the need for pulse oximeter in all the places of delivery. And we should connect the sensor to the right wrist because that measures the preductal saturation. And preductal saturation is measured because this is the same blood that perfuses the coronaries as well as the brain. So this graph shows the normal saturation of the term newborn without any risk factors who cries at birth. As you can see, a baby who at the time of birth has saturation of only around 70, and it gradually picks up to 85 to 95 by 10 minutes of age. And that is what is given in the target saturation. So if the baby whom we are resuscitating, if the baby saturation is around 70 to 75 at 3 minutes, there is no need to give oxygen. But at the same time, if the saturation is 95 at 3 minutes, probably we need to reduce the FiO2. And if the baby's saturation is 60 at 3 minutes, probably we need to increase the FiO2. So this gives us a guide to the saturation, to the FiO2 that needs to be administered to the babies during resuscitation. And we need to have this chart in the resuscitation trolley as well. So how do we titrate the oxygen that's been given to the baby? We can use the blender, wherein you can dial the FiO2 from 21 to 100%, Or in places where there is no blender, we can use a Y connector. So Y connector, we have one flow meter which is connected to the air, the other flow meter which is connected to the oxygen. So based on the amount of gas that we mix, like 3+3 or a 4+2 or a 2+4 or 5+1, we can titrate the FiO2 that's being delivered to the baby. So for term neonates, resuscitation should always be started with 21% oxygen. We should never start resuscitation with 100% oxygen because there is increased mortality. And when all the babies for whom resuscitation was started when room air had a reduction in short-term mortality. And preterm neonates, we can start anywhere between 21 to 30%. Still, it's not very clear, but up to 30%, it's okay. So how do we give oxygen for these babies? The two ways, either by free flow oxygen, wherein we hold the tube closer to the baby's nose, or by using a T-piece resuscitator. So this is a Y-piece connector that we use for transport of babies in our unit. So we can have, in the resuscitation trolley, we have an air cylinder and an oxygen cylinder, and we connect, which are connected by an Y-piece. As you can see here, we have a table which shows if you add 3+3, we get 6. Based on this, we titrate the FiO2 that is being delivered to the neonate. Now comes the most important step in neonatal resuscitation. So if the baby is not breathing or gasping, even after initial steps, and the heart rate is less than 100 per minute, then we need to go ahead doing a positive pressure ventilation. At the same time, we have to connect the saturation monitor and consider ECG monitoring as well. So the most important step, sorry, somebody.
Somebody is unmuted. Please kindly mute it. There are a lot of background disturbances are coming. Members, viewers, please.
So the most important step in NRP is effective positive pressure ventilation. So the indication for positive pressure ventilation is any baby who is apneic or gasping, or if the baby has a heart rate of less than 100, even after the initial steps, then we have to consider positive pressure ventilation. The equipments that can be used is self-inflating bag and mask. The main advantage of bag and mask is it's easily available, it's very economical, we don't need any compressed source of gas. But the disadvantage of self-inflating mask is we're not able to provide PEEP with the self-inflating mask, and we're not able to titrate or measure the amount of peak inspiratory pressure that we're delivering to the baby. So the alternative is T-piece resuscitator. The advantage of T-piece resuscitator is we're able to give PEEP and we're able to decide the PIP that needs to be delivered to the baby. But the disadvantage is it's expensive and we need a compressed source of gas to run the T-piece resuscitator. So once we have decided that we're going to go ahead with positive pressure ventilation, we should call for help and connect the saturation probe and clear the airway. We should position ourselves at the head end and position the baby's head to the sniffing position. And we should choose the appropriate mask, which will cover both the mouth and the nose. So this is the correct mask, which covers both the mouth and the nose. It should not be small because it does not cover the mouth completely, or it should not be large. So it should be an appropriate mask. And once you have chosen the mask, we should place the mask on the face, starting from the chin and then going on to the bridge of the nose. And we should secure an airtight seal between the mask and the face with the thumb and the index finger encircling the rim and the other 3 fingers on the mandible to just pull the jaw. When we are using a round mask like this, holding the stem and giving a slight downward pressure is more than enough to achieve an airtight seal, because that is very much important to deliver effective positive pressure ventilation. So once we have achieved a good seal, we have to start ventilation. The ventilation rate is 40 to 60 per minute in the sequence of breathe, 2, 3, wherein during breathe we squeeze and during do 3 we release. And the peak inflation pressure that can be delivered when we are using a T-piece resuscitator is around 20. And the inspiratory time that we can use while we're using a T-piece resuscitator should be less than 1 second. So how do we assess our positive pressure ventilation? What is the indicator for an effective PPV? So we have been telling again and again, it's not just positive pressure ventilation. It has to be an effective positive pressure ventilation. The most important, the best indicator is the rising heart rate. So we have started PPV. We assess the heart rate after 15 seconds of PPV. If the heart rate is increasing, we know it is effective. So we continue PPV for another 15 seconds. And then we go ahead with assessment again after a total of 30 seconds. What if the heart rate is not increasing after 15 seconds of PPV? Probably the PPV, then we have to look at the chest movement. If the chest is moving, if chest is moving, yes, your PPV is effective. So we continue PPV and reassess heart rate after 15 seconds. But the heart rate is not increasing and chest is also not moving, then probably we have to think that our PPV is not effective and we have to go ahead with a ventilatory corrective steps or MR SOPA. So MR SOPA stands for, M stands for adjusting the mask. So we adjust the mask again to ensure a good seal on the baby's face. And we reposition the airway by adjusting the head to the sniffing position. So after we do these things, adjusting the mask and repositioning, we attempt to ventilate again and reassess the chest movement. If there is good chest movement, we continue the same for another 30 seconds and do the reassessment. But if still there is no chest movement, we go ahead with the next two steps, which is suctioning and opening the mouth. So we suction the mouth and the nose for secretions. We open the mouth slightly and move the jaw forward and keep ventilating with the mouth open. So again, we try PPV and reassess the chest movement. Chest movement is there, we continue PPV for 30 seconds. No chest movement, then probably next step would be to increase the pressure. If you're on a T-piece resuscitator, we can go up to 30 or 35. But if you're on a bag and mask, probably you can increase the pressure that is being by squeezing hard on the bag and mask. But still, if you're not able to achieve a good chest movement, probably we should consider an alternative airway like endotracheal intubation or laryngeal mask airway. So we should always remember MR SOPA has to be considered before we go ahead with the next step of chest compression. So the take-home messages is anticipation and adequate preparation is the key for any neonatal resuscitation. Delayed cord clamping is a simple intervention that can help both preterm and term babies. And we should provide skin-to-skin care for all the babies. The most important step in NRP is effective positive pressure ventilation, not just positive pressure ventilation, but effective positive pressure ventilation. Endotracheal suctioning is not indicated in non-vigorous Meconium and amniotic fluid babies. And MR SOPA should be done in cases of ineffective PPV. And with regard to oxygen, resuscitation should begin in 21% oxygen. And based on the baby's saturation, it should be titrated further, either with a blender or a Y-piece connector. Thank you.
Thank you, Balakrishnan, for your wonderful presentation on essential NRP. I don't think there is any questions in the chat box.